of this disease, not heard of, not much heard of critical care and ICUs and everything like that. So, and COVID hits our country, and it turns out that COVID is a severe respiratory illness where a larger proportion than previous respiratory illnesses, unlike even more than influenza and other respiratory viral illnesses, landed up in the ICU. They landed up in the ICU. They ended up staying in the ICU for longer, and as a result, we had a situation where suddenly the ICUs were strained. Yes, we could create beds, we could create ventilators, but did we have the physicians, trained people who can manage such difficult patients in an ICU? Then we had ventilators. We did not have people who could operate. We did not have experts who could operate and run these ventilators, and as a result, the ventilators were underused. They are locked up criminally so often. And it took a pandemic to recognize that there is a role of an intensivist in the healthcare system. And I'll be taking this opportunity to just show around on what happens to a patient who's going to be admitted into the ICU with severe COVID. And during this process, you will get to know who this intensivist is, who's in a hood and mask, who's going to take care of this patient and what is his role and what we do. So it's going to be a scenario. So we're just going to start with this scenario. That is something which we commonly see in our everyday practice and go through it as it happens every day in the ICU. Let's not forget the importance of protecting oneself while talking about managing COVID. Personal protective equipment. I think a lot of discussions have already happened with regards to this. But let's still just quickly run through it. Always don't forget, use the N95 mask, face shield, full-sleeved glove, non-sterile, full-sleeved gown with non-sterile glove. You could use 2 gloves if required. It may not be necessary to wear a full suit, head cover, and foot covers anymore. But make sure that you use the N95 mask and gown when you enter to see this patient that you're going to see. And let me give you the scenario first. So this is a typical case. So he's a 45-year-old male patient, a diabetic with a history of recent travel. He's had a history of fever since 6 days. He comes to the ER. He's breathless. He's tachypnic. His respiratory rate is 40 breaths per minute. And his saturation on room air is reported to be 80%. And as oxygen therapy is initiated. Initial ECG echo appears normal. A chest X-ray is ordered. And this is what you see. So in this case, do you suspect COVID? Yes, of course, this is a talk on COVID. So it's going to be COVID here. So and should this patient be shifted to the ICU? So this is what we're going to deal with. This is the first few questions that we're going to deal with to begin with. So the diagnosis as well as risk stratification is the first questions we're going to deal with. So here, clearly, the history suggests fever, 6 days, breathlessness, travel history, a patient who's diabetic, looks like ECG echo are normal, probably ruling out another cardiac cause, and you get this typical X-ray, typically with ground glass opacities, which are peripherally distributed with more such opacities in the middle and lower aspects of bilateral. So this is a case patient you would generally suspect COVID. Now, the question is, what next? So first, we need to initiate the diagnostic testing. Just go through what happens to the virus, what are the tests that are available before us. So initially, after an exposure, there is a period of incubation periods, around 7 to 10 days in a patient usually. There's a phase from the incubation period and to the initiation of symptoms, which is a pre-symptomatic phase. Then there are symptoms and then there is a recovery. So usually the symptomatic phase lasts around a week to 10 days. And it has to be noted that I'm going to be discussing mainly about these 2 tests, the Rtpcr and the rapid antigen. The rapid antigen tends to become positive even in the pre-symptomatic phase and remains positive even after the symptoms are abated for a few days. While the rapid antigen test, it has a shorter during which it can be detected. So just before it's pre-symptomatic to about a week, this is when it can be used for detecting COVID. So this timeline is important when you're going to look at the clinical aspects. So just in comparison, basically the PCR is going to detect the viral RNA, and the result, it is more specific in general, while the rapid antigen test will detect the viral protein, so it is less sensitive. So how do you interpret this? An RT-PCR which is positive or a rapid antigen test which is positive, reasonably good weightage. So it's going to be very unlikely there's going to be a false positive with either of these tests. But if it's negative, I think the rapid antigen test, being less sensitive, has a disadvantage with compared to RT-PCR, which is more sensitive. And it also has other advantages in that it can be performed in both upper and lower respiratory tract samples. And but there are some disadvantages. It requires a molecular lab setup in general and more skilled manpower. The turnover time is often a little bit longer. The rapid antigen test, for instance, can be done only with the upper respiratory tract specimens. As I had already discussed, it's going to be positive only for a brief period of time. The sensitivity beyond this period is even lower, but it is highly specific. So there are not going to be too many false positive. The other advantage is it can be done point of care. It can be done in your ERs. It can be done at bedside. The rapid turnover time and requires less skill compared to an RT-PCR test. So what do? I'm just going to just quickly point out that in most situations, you are going to choose an RT-PCR test. So when will you not do an RT-PCR test? It's going to be situations when the RT-PCR is going to be delayed, when the turnover time is high. Your lab does not have an RT-PCR, then probably we'll go for the rapid antigen test. If the RT-PCR test is positive or the rapid antigen test positive, there's no further doubt that this is going to be a COVID. And straight away, we can initiate treatment as well as isolation precautions, considering that this has been a suspect. If the two are negative, though, then there's no point repeating that rapid antigen test again. If the rapid antigen test is negative, we do a PCR, and the PCR preferably with the lower respiratory tract sample in this case. Or you can repeat it if the PCR again comes negative, there's a strong suspicion, there's a strong clinical history, exposure history, or a radiology suggesting positive, very high likelihood of COVID, then probably repeat a PCR, but maybe with a different gene target. So these are the options. The other situation that you're also going to face in the ICU is there are patients who are going to come who are not coming with COVID symptoms, but with different symptoms, different reason for admission to the ICU, but are high risk. So you need to rule out COVID. In these cases, always prefer PCR. If they are negative, then there's no further testing required. So now the first step is completed. We have completed the diagnosis. Order PCR first. Once PCR is done, we confirm the diagnosis. The next thing is we have to decide is this patient should the patient go to the ICU? So I'm going to use 4 aspects here. I'm going to use clinical severity. I'm going to use pre-existing risk factors. I'm going to use biochemical tests, and I'm going to use radiology to come upon this decision. So this pyramid is just going to describe the severity of COVID, and I'm using the WHO definition here. I know in Apollo, we use a different definition as well. We use a category-based definition, category A, B, C, but I'll just stick to it for a more generalized perspective and to avoid confusion. So this type of COVID, mild and moderate. Mild is basically just signs and symptoms of COVID, but no shortness of breath or any abnormal chest imaging, or moderate COVID, where there's only a radiological evidence of pneumonia, but the saturation is okay. These are less likely to get admitted in the ICU, and these compromise most of the cases of COVID in the community, about 81%. Now, what we are going to be interested about is these 2 categories, a severe category and the critical category. A patient is said to have severe COVID when the saturation is less than 94% on room air and a PF ratio less than 300, having respiratory distress defined as a respiratory rate of more than 30 and lung infiltrates more than 50% lung involvement. This constitutes around 14% of cases that come to our ICU. and critically ill COVID, which is severe respiratory failure. This is the category of patients who are going to get intubated, are going to go on an ECMO, who also have additional septic shock and multi-organ dysfunction. So this constitutes about 5% of the patients who get admitted to the ICU. And it's only these two categories predominantly, critical and severely ill COVID, who are going to get admitted to the ICU. This question is direct. But there will be a small category of patients from the moderate ill who may need admission into the ICU, and who are they? So for this, I'm going to use the pre-existing illness criteria. So these possible, this is what CDC says, the list of illnesses which will be constituting as high risk when associated with COVID, commonly encountered: cancer, COPD, diabetes, heart conditions, pregnancy. So these are the conditions commonly encountered in your ICU. Note that hypertension is not one of these comorbids that is listed by the CDC. So if there's a patient with moderate illness with one of this may be supported by one of these lab features, then you'll again have to admit in the ICU. So I do recommend, and in general, we do recommend to do these biomarkers. There's a lot of controversy whether they should be done at all. Do they increase expenses? But I would suggest to do them. The commonly done biomarkers, you don't have to do the entire list, but maybe you can use one or two of them. You can use D-dimer, CRP, LDH, along with other hematological parameters such as an absolute lymphocyte count, or a lymphocyte neutrophil ratio, or red cell distribution width, or any one of these, to make that call whether this patient has to be admitted to the ICU. So I've given you the normal ranges. These ranges above which, then generally it is accepted that they are associated with severe COVID. So first, clinical; second, comorbids; third, biochemical; and fourth, I will also use radiology. Again, another controversy, whether radiology should be routinely done. So which radiology? Is it an X-ray enough? A CT is required? So I'm going to I'll try to answer some of those questions. So first, I don't suggest that a CT should be used for diagnosis, unless maybe the center that you work in does not have a PCR or a rapid antigen test. But I would use a CT to identify high-risk patients among the moderate disease category who are likely to deteriorate. This I will use to decide on whether the patient needs to go to the ward or to the ICU. We know that there are various different CT scores available based on distribution of lung infiltrates, then the severity. And in general, a plain CT is adequate. It's not necessary to perform a CT pulmonary angiogram or a contrast CT for all patients. But I would use a CT for deciding for risk stratification. So if the patient is already sick and a CT can't be done, an X-ray should do. And in addition, in the ultrasound, I would suggest to use a point of care ultrasound in order to assess and assess the response to therapy. Ultrasound at bedside can also be useful, especially if the patient can't be shifted to a CT room. Coming back to the next case. So we have now moved on. This patient has been classified as severe COVID, as and per other definitions, category C. So he's detected to be PCR positive. He's then now going to be shifted to the COVID ICU with isolation. Not going through details about the isolation precaution. Maybe Kavita will also be discussing about that. Basically, it has to be ideally a negative pressure room or just a single occupancy room. You can use additional filters, HEPA filters, but it has to be a single patient in a room kind of a system, unless the next patient is already detected as COVID. CT severity of 22 out of 35 has been noted. The patient is now started on non-rebreather mask oxygen at 10 liters per minute and a saturation detected as 92%. This is a CT. And now what is the next line of management? So what is the respiratory management and what is the pharmacological management? These are the two questions I'm going to try to answer. And in order to before trying to answer that, I think we need to understand the pathogenesis of COVID in order to understand how the various clinical therapies work and what are the targets. So the first thing that happens is the entry of the virus from another infected host to the new host. The SARS-CoV-2 virus now enters, and the spike protein, using the spike protein, it attaches to the respiratory epithelium via the ACE2 inhibitors. It then cleaves into the cell, as you can note. It cleaves into the cell And then the viral RNA will instruct the host cell to multiply and produce more viral copies. So now this is the first step. So this is the step of direct viral entry and production of more viral copies or viremia. The next step is the reaction of the host to the increased viral copies. We don't know which patients will get this step. Not all patients go through this step, but the patients who do land up in the ICU generally go through this. So what happens is there is an endothelial cell damage, endotheliitis, and provoking of thrombin formation. And then the lymphocytes that come there is a dysregulated immune response, and some patients develop this cytokine storm or massive release of hyperactive innate immunity, which will cause most of the damage, including ARDS. And as I already mentioned, an endothelial inflammation will promote thrombin formation and decrease fibrinolysis and causes clotting and thrombotic complications of COVID. So these are the three main points at which the pharmacological targets are directed at. So the first step for direct viral entry and viremia, antiviral therapy. To prevent the cytokine storm or manage it, we use the immunomodulators. And for the thrombosis, we use anticoagulation. So this is what happens generally. This is the timeline. So I had already discussed about how the early phase is when the viral replication happens. This is in the first week. There's a viral phase which gradually tapers down. And it is this point when the viral load is maximal is when some patients it triggers a host inflammatory response and a dysregulated immune response and triggers the cytokine storm. And this is the phase at which the patient becomes short of breath. And in some patients, they proceed on to multi-organ dysfunction as well. And it is in this phase you see all the increased biomarkers. So this timeline, please remember while I go through the next topics as well, there is a phase in which both overlap, the viremia phase as well as the inflammatory phase. So the main targets like antiviral drugs work in the viral response phase, and the main other immune modulators like dexamethasone will work in this phase, the phase of inflammation. And it is during inflammation when the patient becomes hypoxic and you need oxygen. So with regards to the management of COVID in the ICU, I'm going to deal with two main aspects. One is the pharmacotherapy and the organ support, and they both go hand in hand. They are both important and they both go hand in hand, and they both must be managed simultaneously. Starting off with the pharmacotherapy, in this particular phase, what are the things that you need to do? So I'm going to need to do is therapies that target the virus and therapies that reduce the inflammatory cascade and anticoagulation. So what are the therapies that target the virus? Antiviral drugs such as remdesivir, interferons, ivermectin, hydrochloroquine, all these drugs will target the virus in this phase. These are the antiviral drugs. There's another category of drugs which will also be beneficial in this phase, the early phase, and that is passive immunity. Basically, we mimic the host's humoral response by giving convalescent plasma or monoclonal antibodies, which will then destroy the virus and reduce the viremia. So these are the therapies that target the virus. The common thing is they have to be given early. So just a very quick discussion on remdesivir. There's been a lot of discussion in general. So will I use remdesivir in a severely ill patient? I may not be using in the category of patients who are ventilated or an NIV. I might not be using remdesivir in a patient who's not even in oxygen. There's going to be one very small subset of patients who I'll be using remdesivir. Who are these patients? These are patients who are on low flow oxygen or more just about going from low flow to high oxygen. And it is in this particular population of patients where remdesivir has been shown to be having some benefit. But even the benefit demonstrated here is more of a relative reduction in length of stay and not mortality, maybe a reduction in the probability of being transferred to the ICU. The other category where there is no oxygen or the patient is already pretty bad shape, then remdesivir is of no use. And as a result, basically, because it only reduces the length of stay, it's going to be useful in pandemics to reduce probably the resources, that is the resources in terms of hospital or ICU beds. But even here, there's a lot of controversy. There may be physicians who will argue that they will admit patients for remdesivir and it doesn't solve the purpose. So remdesivir entirely controversial. So going back, what it does is it may reduce the time to recovery, doesn't have a role in critically ill subset, and WHO clearly says that as per the Solidarity trial, the WHO living guidance does not recommend the use of remdesivir. And dose that, if it's going to be used, is going to be 200 mg IV on day 1, followed by 100 mg IV for 5 days. Some people recommend longer therapies in patients with mechanical ventilation and Ecmo. There is no real evidence for this. Prefer to use it more carefully when the GFR is less than 30. So first drug out of question. Just a reminder, remdesivir is a novel nucleotide analog. I'm just saying this to differentiate it from the other antiviral drugs. So coming to the, I'll be talking about the other antiviral drugs later. I wanted to discuss about the monoclonal antibodies. So now there's a lot of interest with the monoclonal antibodies. Basically, this drug, the Regeneron, which is a combination of casirivimab and imdevimab. So how is this beneficial? Initially, this particular monoclonal antibodies were tried in high-risk patients in the OPD criteria, basically high-risk OPD patients, to prevent admission to the hospital. And this is where the initial EUA provided by the FDA was. It is being used in many of the hospitals still. It is used at a lower dose. Basically, it is to be used together, 600 and 600, and it was used in the OPD patients. But then now, there is a yet to be published data done by the recovery group investigators, where they did an RCT using monoclonal antibodies in hospitalized patients who are on oxygen in the early phase. And there's a pretty large RCT, around 10,000 patients were there. What they found was there was no reduction in overall mortality when this was used in this category of patients, that is the hospitalized patients who are hypoxic. But what needs to be noted is when they did a subgroup analysis of one particular group, that is the patients who were seronegative, in this particular category, it seemed that monoclonal antibodies were beneficial. They were beneficial, to be noted that it were beneficial at higher doses, almost doses up to 4 grams of each of them. So what is the take-home message? It does make sense that monoclonal antibodies will help, considering many of the high-risk patients do not mount a good humoral immunity, and giving the passive antibodies are going to help. But as of now, the EUA is for, that is the emergency use authorization is for OPD patients. The data needs to be published before we can make conclusive thought processes whether it should be used in the hospitalized patients in seronegative individuals. But this is the current evidence. And similarly with convalescent plasma, again, it makes sense. It is antiviral because it has humoral immunity. Again, it's useful if given early. Initial trials, which when they did, they used plasma with high antibodies and given very early in the disease, and many reported benefits. There was extensive, campaigns to donate plasma. But let me just summarize it. At the moment, plenty of evidence to say convalescent plasma is not useful, definitely not useful in the ICU. That's the take-home message. Our own Indian data is available from the ICMR Placid study, and I don't think convalescent plasma should not be used any further. I think the convalescent plasma should not be used any further in the ICU. There are still could conduct trials with high titer plasma early in the disease, but that is in a trial basis. So basically what I'm trying to say is monoclonal antibody is probably an S, and a convalescent plasma are probably a no. What are the other therapies that are available before us? I'll just quickly go through this. We've had a whole list of medicines that were said to be possibly beneficial in COVID. Ivermectin, number one. Yes, it did have antiviral effect in vitro, but many clinical trials also said it could be beneficial, but many of the trials are small, very poor quality, and the take-home message is no, not ivermectin, and especially not in severely ill patients. It is not that it has no side effects as well. There are gastrointestinal neurological side effects noted. The only time I will use ivermectin is I'm using it for preventing strongyloids reactivation, especially when starting dexamethasone, a single dose of 12 mg. Hydroxychloroquine, just a reminder, the EUA for HCQ has been withdrawn. You are no longer authorized to use this. Lot of side effects. Interferon beta again generated a lot of interest, but even now the evidence is lacking. Favipiravir, promoted by many of the Indian companies, basically an RNA polymerase inhibitor, but this is another drug which has no benefit, especially not in the ICU. No, not clopidogrel, ritonavir, not azithromycin, and also not vitamin D. Again, vitamin D you can give if there is a deficiency, you want to supplement, but not for treating COVID. So these are the antiviral summary of the antiviral therapy. I just want to briefly touch upon one promising drug, which is molnupiravir. This is basically a new drug which has demonstrated very promising phase 3 results. Just last month, we had the preprint data available. Why is it promising? Because it is oral. Why is it also promising? Because it reduces hospitalization in newly diagnosed high-risk patients. And it is not yet available in India. So fingers crossed, let's see what happens to this drug. So after the antiviral therapy, the next step is, especially in this patient who's on oxygen, is going to be to start immunomodulators. And why? We've already discussed the pathophysiology about the cytokine storm. And what are the immunomodulators that we have? We'll be discussing the different ones during this presentation. First is the steroid. I think early on in the pandemic, there was a lot of hesitancy with regards to steroid use, probably coming out of the previous evidence that existed for steroid use in other viral ARDS illnesses, especially MERS and SARS, and maybe even influenza. But all doubts were completely answered by the recovery trial. This large RCT, which demonstrated that the use of dexamethasone at a dose of 6 mg in hospitalized patients with COVID-19 definitely had positive effects, definitely reduced mortality, and definitely also had other good secondary outcomes like early discharge, less progression to mechanical ventilation, and this benefit was seen across all subgroups. This is dexamethasone demonstrating lower mortality in the entire population of 6,000 patients. This is dexamethasone in patients who are on intubation. You can see the benefit is maximal in the intubated category. This is in patients who are just on oxygen. The magnitude smaller than with intubation, but still benefit, statistically significant benefit. And only in one category, that is when patients who were not on oxygen, did we see the opposite effect, that dexamethasone was causing harm. So this is a key take-home point. Use dexamethasone in all patients who come to the ICU, and I assume all patients who come to the ICU generally need oxygen. So this was further confirmed by the WHO meta-analysis which was done, which just followed the recovery trial. It included, I think, around 6 or 7 different RCTs. So as a result of which, all major organizations, NIH, IDSA, and WHO recommend steroids for severe COVID or any COVID with need for mechanical ventilation or supplemental oxygenation at a dose of 6 mg for 10 days. We will note that sometimes in Indian setting, the specific salt or product that we use delivers only 6 mg, will be given as 8 mg. So just to point that out, and recommend against using dexamethasone in patients not requiring supplemental oxygen. The next therapy, we've dealt with antivirals, we've dealt with steroids. I'll be dealing with rescue therapy, the other immunomodulators, a little later, but the next thing is anticoagulation. So in anticoagulation, I'm going to talk about trying to answer some questions. It is pretty clear that COVID is a hypercoagulable state, especially critically ill, which is already in a state of high risk of thrombosis. And any patient with this hypercoagulated state will also have an increased mortality. And as a result, anticoagulation is routinely started in COVID. I'll try to answer these points. Should it be used? If used, at what dosing? Is it beneficial to use something in between? And when to use? And is there anything else that needs to be used, like a D-dimer? to guide anticoagulation. So should it be used? First, we recommend that anticoagulation should be used in all patients in ICU. Is there an evidence for this? Yes, there is an evidence in terms of a large study published in BMJ, where early initiation, that is in the first 24 hours of prophylactic anticoagulation, was improved, was associated with better outcome compared to no anticoagulation. So first to be answered is anticoagulation on patients who are admitted to the ICU, but except if the patient had bleeding complication. But at what doses? It should be at prophylactic doses. I'll be dealing in when we use therapeutic doses, but it should be predominantly in prophylactic doses in all category of patients, either it's medical, surgical, or obstetric. I would recommend a dose of enoxaparin 40 mg once daily or dalteparin 5,000 units once daily. So why? I'm going to go through some evidence here. So this is the remap cap along with the ACT4 and ATT-AC trials. This is basically a trial conducted on 3 different platforms, multi-center adaptive RCT on the efficacy of antithrombotic strategies. And I'll summarize the results. So in critically ill patients, the strategy of therapeutic dose anticoagulation did not result in greater probability to survival. So this is the key point. So basically, the first study clearly demonstrated that in the category who are critically ill, therapeutic dose anticoagulation was not beneficial. We've already established that prophylactic dose anticoagulation is beneficial. Anticoagulation is beneficial, but not at therapeutic dose in critically ill. There was another study which is also conducted in moderately ill COVID patients. In this, there was a tendency towards benefit, that is, with increased probability of survival to hospital discharge with reduced use of cardiovascular or respiratory organ support with the therapeutic dose. But I will ask you to take this with a pinch of salt. The statistical significance reach was just about barely significant, and there are a lot of factors which we cannot assess. And as of now, most of the societies recommend that anticoagulation should be used at the prophylactic dose. Is there a use of using something in between, either not a prophylactic dose or not a therapeutic dose? Here, I'll just refer to the inspiration trial that was published. So using an intermediate dose also does not improve outcomes. So predominantly use prophylactic anticoagulation in all patients except contraindicated. No role of therapeutic dose, no role of intermediate dose, that is 1 mg per kg OD, something like that. When anticoagulation should be used in therapeutic, if there are clear indications for therapeutic, that is a DVT, a PE, or a massive MI or a stroke, then we use therapeutic anticoagulation. And they can also use therapeutic anticoagulation in this category of patients who are already on therapeutic anticoagulation, such as a patient who has AF or something like this. So even in those, we shift to a shorter acting agent from their usual oral therapies. So very often we use the D-dimer to make decisions. I would recommend the D-dimer to be done, but this is to correlate levels of severity and to prognosis, but not to make decisions on anticoagulation, because D-dimer in a case like COVID is generally elevated because of inflammation and thrombosis. So it's going to be very difficult to differentiate between the two, and it is not useful to do D-dimer on a routine basis to decide on anticoagulation. So that is the summary with regards to anticoagulation. Also want to point out that there is no role for aspirin and other antiplatelet or any role for tissue plasminogen activator other than the routine established indications. Coming to the respiratory therapy. So the oxygenation target. So what should be the oxygenation target? In general, it should be around 90 to 94%. In some patients, such as patients who are having COPD or ILD, it should be around 88 to 90%. Patients who are pregnant, around 95 to 97%. And patients who are having flow deficit conditions where delivery of oxygen at the tissue level is going to be low, such as ACS or stroke, then again a similar target to that of a pregnant woman. This is from the Apollo Chennai protocol. So always individualize and titrate FiO2 to lowest acceptable target at which the patient is comfortable. always remember to conserve oxygen. Use the saturation probe and ABG to make these decisions. This is something which we have been doing in Apollo Chennai, especially when we had the oxygen shortage. We have introduced placards at patient bedside, clearly informing to the nurses what the saturation goal is to this particular patient. Basically, we individualize, try to conserve oxygen, and optimize oxygen use. There are different delivery systems that we use. There is the oxygen should be delivered as a high flow or system or as a low flow system. So what needs to be remembered is what is high flow system is a flow exceeds the patient's peak inspiratory flow demand, and it delivers higher oxygen. The systems such as NRBM and HFNC are high flow system. Low flow systems are those systems where the flow is less than the patient's peak flow. If the flow is less than the patient's peak flow, air is entrapped from outside, and as a result, FiO2 deliver depends on the patient's respiratory rate. So devices such as nasal cannula and face mask will fall under this category. So just to brief on the various oxygen deliveries systems, nasal cannula will deliver oxygen in a low flow system. It should be used in mild disease, and it should be used a flow of up to around 6 liters per minute, and the FiO2 delivered varies between 24 to 35. Face mask is also a low flow system, can be used at flows of 5 to 10 liters per minute. Delivered FiO2 is around 28 to 40%. It should be used in moderate hypoxia. Other devices, we use high flow systems up to above 6 liters per minute. FiO2 delivered could be around 60 to 90%, and it should be used in severe hypoxia. What are the positive pressure devices? All the devices shown in this picture are positive pressure devices. Basically, HFNC, the CPAP machines, BiPAP machines, or the ventilator NIV. So just a brief summary of the various positive pressure devices that we have. HFNC will deliver some CPAP, with the CPAP increasing by 1 centimeters of water with every 10 liters per minute flow increase. BiPAP and CPAP differ in that there is 2 levels of support in BiPAP. We tend to use BiPAP if there is a separate indication for BiPAP use, such as hypercapnic respiratory failure or COPD. In general, we tend to prefer ventilator NIV used as P plus pressure support modes. These devices have an internal blender. They're capable of delivering FiO2 up to 100%, and they deliver a fixed oxygen and are capable of delivering more oxygen. And because they have there are double limb circuit, the chance of aerosolization is also reduced, so thereby reducing infection risk. So what is our protocol with regards to oxygen delivery? We start with the nasal prongs and then titrate up to around 6 liters per minute. If it crosses 6 liters per minute, we change to face mask. Between 6 to 10 liters per minute, we use face mask, following the various oxygen targets. If demand is more than 10 liters, we use HFNC or NIV. We use NRBM just in between to give breaks from these devices. And HFNC, when we initiate, we start at high flows and then down titrate. NIV, we tend to prefer to use with dual limb circuit. And please remember, although the oxygen crisis is now currently not there, all time try to conserve oxygen as much as possible. So how in this patient, whether to choose between HFNC or NIV, it is an individual choice. You have to individualize for each patient. We would prefer HFNC over NIV. This is based on evidence from not from COVID, but from non-COVID ARDS. And also that fact that in the previous pandemic with MERS, NIV was less tolerated. And prefer NIV if NIV has other established indications for NIV are there, such as COPD or acute cardiogenic pulmonary edema. One can transition between the two devices. This is often the case. It makes HFNC efficient and NIV more practical as well. So there is also other devices that have been studied, such as the HFNC, the helmet NIV. There's a study which demonstrated that this particular device was superior to the HFNC, but our experience is lesser. Also suggest using other adjuncts, and this I would particularly recommend is the awake prone position. Awake proning can be used along with high flow low flow devices, even with HFNC and NIV, it has to be voluntary at all times, because it's very difficult to force and involve a patient who's resisting and not comfortable in the prone position to, forcibly prone. We recommend that at least 6 to 8 hours a day out of 24 hours, if the patient is cooperative, to try this awake prone position. What we have noted is it always improves oxygen. Almost every patient, oxygenation improves. It is usually well tolerated. Does it lower the chance of getting intubated? There is one study which has shown that it could probably reduce the chance of getting intubated, but there is no improvement in overall outcomes and mortality. I would recommend that all hospitals, try using the awake prone position in patients who are hypoxic. It is very useful. With regards to nebulization, not to use routinely. It increases aerosolization, and use only if there is established indications such as bronchial asthma. Going back to the case, the patient has been categorized as severe COVID, and the CT severity now is 22 out of 35. He's on NRBM and HFNC. DEXA has been initiated, but he still remains hypoxic and tachypneic. What to do next? So with regards to this, I'm going to discuss the rescue therapies. The rescue therapies, I'm going to deal with pharmacological as well as the respiratory therapies. And the rescue therapies that are available towards us are the immunomodulators, basically the IL-6 inhibitors, JAK inhibitor, high-dose steroids, and others such as IL-1 inhibitors such as anakinra. So we'll just briefly go through this in the next 2 minutes on which one to choose and when to administer, and what are the contraindications, when to use. So I'll come to the drugs. When we use this, when we admit a patient who's hypoxic in the ICU, who's initially on low flow oxygen devices, and this particular patient rapidly worsens within a period around maybe around 72 hours, within the first 3 days in the ICU, if the patient directly gets worse and gets hypoxic and has to be started on an NRBM, or if the oxygen need is rapidly increasing, maybe by 6 liters per minute by day, then we would, and you have already tried using dexamethasone and all probably guided by therapies such as CRP, then we would use this drug, the immunomodulators, either tocilizumab or baricitinib. If the patient is going to get intubated, severely hypoxic, then we would suggest to use tocilizumab. I'll just get to why we do this. Tocilizumab is an IL-6 inhibitor. We use it at a dose of 8 mg per kg. It can be used in both intubated and ventilated and Ecmo patients. Sarilumab is an alternative. We have significant evidence from the Remap-Cap trial as well as the recovery trial, which used in tocilizumab in the said indications. That is, when as I had already discussed, patient rapidly worsening hypoxic, inflammation increasing, and DEXA has been trialed. And both these trials showed an absolute reduction in mortality. In terms of Remap-Cap, it was 8%, and in terms of recovery, it was 4%. So all the guidelines now, including WHO, NIH, CDC recommend using tocilizumab. With regards to baricitinib, it is a JAK inhibitor. It also has some antiviral effect. We'd use with caution if the GFR is low, and it is advantageous in that it's oral. Its dose is around 4 mg per kg. Some have noted that it has some antiviral effect also. There are 2 trials, basically the ACT2 trial and the Cove barrier trial. In the ACT2 trial, it has been used and it has been shown to be beneficial in a small category of patients where it is used along with remdesivir. And in the Cove barrier trial, it was shown to be beneficial along with without using remdesivir. So remember that in both these trials, intubated patients were not there, and in the intubated category, there was no real statistical benefit. So I would use baricitinib in patients who probably are very hypoxic on NRBM or HFNC or NIV. So currently IDSA, NIH also recommends it, not WHO. Don't ever use toci and bari together. I've just come up with a new alternative is if both tocilizumab and bariatric are not available. Is option that is there. Is there any other option? So I'll just introduce you to the COVID steroid trial, which is recently published, and Apollo Chennai was one of the participating trials, and I was the PI for this particular trial. And basically, it used compared 2 doses of Dexa at a higher dose of 12 mg with 6 mg, and noted that among patients who were severely hypoxic, there was no difference in using dexamethasone 12 mg with compared to 6 mg, but there was some difference in mortality, though not statistical, which is similar to what was there with tocilizumab. In this study, in our trial, we found around 4.5% reduction in mortality. So, although I won't recommend using Dexa in all patients at higher dose, I would suggest that if baricitinib or tocilizumab is not available, we could use Dexa at a higher dose of 12 mg. So there is no evidence for higher or pulse dose of steroid. So back to the case, the patient now severe COVID, we administer steroids and tocilizumab. He's now on NIV, he's still tachypneic. We have given Dexa, and the chest X-ray is worsening. And now this is how he is. He's breathless on the NIV. What to do next? So now we need to intubate this patient maybe. And the question that needs to be answered is, does this patient have ARDS? If by going by the Berlin definition, this patient has ARDS. So what is the Berlin definition? This is a PF ratio. This is hypoxia with a PF ratio less than 300 with a PEEP of more than 5 and a ventilated patient. Acuity, within 1 week of clinical insult, the patient is worsening. X-ray showing bilateral infiltrates. It can be classified into mild, moderate, and severity based on the PF ratio. So decision on when to intubate is again individual. Sorry. So it's very individual. We would suggest if the patient is becoming very tachypneic, increased work of breathing, saturation is less than 90 on an FiO2 more than 70%, then and worsening hypercapnia. If the patient is developing hemodynamic instability and altered sensorium, we may need to intubate such a patient. In some situation, we may need to discuss end of life care situation and DNI situations in appropriate settings. We'll skip this. We're intubating a COVID precaution. Always be safe. That is the most important criteria. So individualize the ventilator setting. The initial ventilator setting should be used as per the predicted body weight. Initiate tidal volume of 6 ml per kg at the volume control mode. So use a respiratory rate at around less than 35 breaths per minute to match the patient's baseline minute ventilation. Basically, this is the low tidal volume ventilation with the specific oxygenation target of 55 to 80 and SpO2 of 88 to 95%. Subsequent adjustments we use based on measuring the P-plat and going down or up on the tidal volume. Basically, stick to the low tidal volume. This is from evidence from non-COVID ARDS. So tidal volume, low tidal volume with a volume control ventilation and with a high PEEP. A high PEEP, how we could use the ArtsNet table on PEEP titration and titrate the PEEP. We would advise using higher PEEPs in order to recruit more lung units. If there is no response to the initial setting, that is defined as a PF ratio less than 150, FiO2 more than 0.6, or high PEEP requirement, we will continue low tidal volume ventilation, but this time we will have to initiate it with prone ventilation. And alternate options are there: recruitment, neuromuscular blocking agents, and inhaled nitric oxide and Ecmo. But I would like to stress on prone ventilation. Prone ventilation, we have seen in our setting and in our trials, it is definitely very helpful as a rescue measure in patients who we are not able to ventilate. We have a high experience using prone ventilation. So who to do prone ventilation? Again, we already discussed PF ratio less than 150, FiO2 more than 0.6, timing as early as possible, and duration up to around 12 to 16 hours per day. And when to discontinue is if you have supine the patient and the patient is able to maintain the PF ratio and with lower FiO2 requirement, at least 4 hours after the last session, I would discontinue prone ventilation. There may be some complication. I think Kavita will be discussing about that. But apart from the absolute contraindications, that is increased ICP or spinal instability or multiple trauma fractures, most other situation we could use prone ventilation. Other rescue measures that are available are recruitment, high PEEP, neuromuscular blocking agents. Inhaled nitric oxide, again, it's very consistently improves the PF ratio, but it does not seem to improve mortality. I would suggest that to be used in patients who have acute pulmonary arterial hypertension and right heart dysfunction. And definitely, you may see that the saturation may improve, but that doesn't mean we delay proning. So that's an important point that we need to discuss. Inhaled nitric oxide, again, is not widely available, and so is the last option that we are going to discuss about, which is ECMO. Again, it's not universally available. Use it as a last resort. That is, we have tried recruiting, we have tried proning, we have tried inhaled nitric oxide and other drugs, and still the patient is not better. We use indications are not similar from non-COVID indications of ARDS. We prefer VV ECMO in general, except in situations where there is severe cardiogenic shock or right heart failure, where we use VV ECMO. There are some contraindications where the patient's prognosis is not going to be good. The patient has MODS and severe neurological injuries, which may not get benefited by putting a patient on ECMO. In those situations, do not use an ECMO. Remember also that COVID is a hypercoagulable state, and patients who are on an ECMO need to have higher APT2 targets. So going back to the case, again, he's got severe COVID. We administered steroids and tocilizumab. After ventilation for 10 days, the patient is now clinically better. We put him on a spontaneous breathing trial. With low FiO2, the patient is able to maintain saturation. The patient is comfortable. X-ray is showing decreased infiltrates, conscious and alert patient who's demonstrating a good cough. So the next thing that we need to do is we have to assess for readiness for extubation. If the patient is conscious, oxygenation is better, hemodynamically stable, there are no other reason why the patient should have a tube in place. We assess for readiness for extubation. We put them on a spontaneous breathing trial. Here we prefer a pressure support based spontaneous breathing trial for a period of typically around 2 hours. Remember, TPs may increase aerosolization, so we don't use it for that purpose. Remember, these patients with COVID are often intubated for long periods. They then tend to have higher risk of extubation failure and reintubation than most. Often suggest that once extubated, try to put them on an NIV or HFNC. If it is not possible to extubate, I think doing a tracheostomy is quite useful. The right time to do a tracheostomy is not quite established, but either a percutaneous or the surgical, both are useful. While doing all these glamorous activities, let's not forget the non-glamorous things which actually add benefit to the patient. In ICU, we use the mnemonic called FAST have bids. Basically, to remember each step of supportive care is basically a checklist. Make sure that we don't remember, and each element of the supportive care is important. So F is for feeding, fluids, electrolytes. A is for analgesia. In this case, with COVID, we use fentanyl. Sedation, we use different RAS targets. Thromboembolism, we have already discussed. Head and neck elevation, bed elevation, ulcer prophylaxis, glycemic control, bowel regimens, and de-escalation of antibiotics. Other supportive care such as VAP and infection prevention are also important, along with mobilization and physiotherapy. So I'm just coming to the end of my presentation. This is the last few slides. So this is a situation that we had. COVID severely strained our resources. Many of our patients were in the ICU for long periods, more than 2-3 weeks, even months sometimes, some of them on ECMO for very long duration. How do we manage this? And how are we going to bridge this? So just discussing various options, tele-ICUs, training non-intensivists, were all possible options. It's going to be taking a long time to double the actual number of intensives that are there. But I'm hoping with this presentation, you understood what an average intensivist does to a patient with severe COVID. So you got to know this person behind the mask, and what an intensivist does. Thank you for letting me speak. Sorry for exceeding the time limit, and happy Diwali. Thank you, Dr.
Thank you, Ajay. Thank you for an extremely comprehensive talk. We are running a little bit on shorter time, but this is such an important topic. I'm glad you went through it, and most of this got recorded. And I was wishing that we had this talk at the beginning of the pandemic, when we could have avoided all the errors and the experiments that we did. Now we really know that really, honestly, basic critical care is what counts. The things we already knew, the low tidal volume ventilation, steroids sometimes work, early mobilization, prone ventilation, none of this is really new. So it's pretty amazing that the principles have held up. And of course, some new drugs have come through, but some repurposed drugs have come through. And I'm hoping that as the pandemic progresses, all these studies come to conclusion. By next year, either we have better vaccines or better drugs. Molnupiravir seems to be somewhat promising, as you said. I know we're running really short on time, but just the beginning part didn't get recorded. So I'm just going to reintroduce Dr. Ajay Padmanabhan as a critical care consultant from Apollo Hospitals, Chennai. He's giving this lecture. He just completed the lecture on critical care and COVID. And I'm Dr. Sai Praveen Hanath from Apollo Hospitals, Hyderabad. And if you're watching this now, you're probably watching a recording. And what we've really gone through today is a complete overview of critical care and COVID. This is under the umbrella of the Apollo Critical Care Excellence Team. So we have the Center of Excellence in Critical Care. And what we've really seen is that with the push to integrate all the Apollos and also reach out to our partner hospitals around the country, these knowledge talks have been really getting really good attention. In fact, we almost had over 90 plus people. And once this gets broadcasted, several hundred people will be watching this. So thank you, Ajay. Again, I'm going to speed up and ask Ms. Bhattacharya to kind of get on and start sharing her slides. So Ajay, you can stop screen sharing. And Ms. Bhattacharya, you can kind of introduce yourself. You're from Kolkata, and you're going to give us the nursing aspects of critical care management in COVID. And I'm sure all of you have gone through quite a bit of challenges with COVID, especially nursing has been right at the front line of this. And again, very thankful and grateful to all our nurses around India, around the world for really stepping up and putting yourselves right in harm's way. Luckily, we had all the good protection and the PPE. So Kavita, kindly go ahead, and you have about 25 minutes or so, and then we'll have a few minutes for questions. If you want to finish sooner, you can take up some of the points in our discussion. Kavita, please go ahead and introduce yourself briefly. Thank you.
Thank you, sir. Namaskar and very good afternoon to all of you. It's been such a great pleasure to be here in this forum. I would like to thank the entire team of ICCP and the Apollo Center of Excellence and Knowledge Series for conducting this webinar. I would like to thank our group directing nursing head, a great leader, Captain Usha Banerjee ma'am, for giving me this great platform. And I sincerely thank goes to our nursing head, Lakshmi Bhattacharya, for supporting and permitting me the part of this webinar. So today we have a topic to discuss on COVID-19 and critical care challenges. COVID-19 is not new to us. COVID-19 is not new to us, and it does not need any introduction. But still, it is responsible for the world's largest pandemic situation and a new challenge faced by modern medicine. A COVID-19 we have seen in last 2 waves that a significant proportion of hospitalized patients with COVID-19 require invasive ventilation, Ecmo, and other ICU therapies. The pathophysiology of COVID-19 is very complex, and the disease compromises various major organs and the body immune system. So we have seen a large population of COVID-19 patients develop some sort of ARDS, ICU-acquired weakness, long-term ventilation and breathing failure requiring tracheostomy, limb ischemia, gangrene, foot drop, though it's very rare, but we have seen in many cases sepsis and septic shock and even death. So when we are taking care of the patient of COVID-19, we have to understand the principle of management of COVID-19. The first principle is treating the underlying cause. This heading is entirely done by the physician, but as a nursing prospect, early recognition, the severity of the disease and its complication is very important. So early initiation of ventilator support and its management is the third most important. And fourth is the most vital for the nurses, where nurses plays a very important role to monitor the different clinical aspect of the patient, record the different parameters, interpret the result, and respond accordingly. And the fifth principle is rendering quality care and patient safety. So here's comes the scenario. Today, So today I'm going to discuss about COVID-19 management in a very sick ICU patient, a case scenario, and I will highlight the complication and challenge we have faced. And end of the session, you will be able to understand the nurses' roles and responsibility and the nursing care plan pertaining to COVID-19 for better outcome. Here comes a patient who is 40 years old gentleman, COVID positive, with no known comorbidities, brought to Apollo emergency. He was treated in outside hospital for COVID-19 pneumonia for more than 40 days. Initially, he was treated with remdesivir, pulse dose steroid, NRBM, NIV, and later intubated for acute respiratory distress even after chronic. On admission, his vital was blood pressure of 110/60 with 10 ml of NORAD, heart rate of 154, SpO2 of 86 to 88% with 100% of FiO2 and temperature of 99 degrees Fahrenheit. He immediately shifted to COVID ICU and started on venous Ecmo support after taking consult with the family. His ventilator setting was ACVC mode with 100% FiO2, tidal volume of 280, PEEP of 10, and respiratory rate of 12. When we talk about COVID-19, we have to understand the physiology of ARDS. I'm not going to detail the physiology of ARDS, but here the nurse's role is very clear, is to maintain the saturation of 94% by initiating supplement oxygen via nasal cannula, face mask, or NRBM. If the patient is not maintaining SpO2 goal of 96%, this patient may put on HFNC or BiPAP. But if there is a persistent hypoxia and there is a sign of worsening of mental status or any mental status, so do not delay intubation, but putting a patient on ventilator is not going to help. So the strategy should be very clear. That is lung protective ventilation. That means a low tidal volume, which is 4 to 8 ml kg of body weight. The target plateau pressure should be not beyond 30 centimeter of HDU. The driving pressure should be 15 centimeter and the SpO2 goal of 88 to 96%. So after stabilization, titrate the FiO2 and maintain a goal of SpO2 88 to 96% to prevent oxygen toxicity. There should be a strict fluid management because we do not want to harm the lungs and the heart. Even after patient on invasive ventilation and high PEEP, patient is not improving, this patient may place on prone position ventilation. Even there is a refractory hypoxia, this patient may be subjected to veno-venous or veno-arterial Ecmo. We have to monitor the patient very frequently for next 48 hours. We have to maintain and monitor the cardiac output, the stroke volume, the index, a series of echoes, the tissue oxygenation marker like SpO2, EtCO2, SO2, considered analgesic for pain management, sedation, neuromuscular blocker, early initiation of enteric nutrition and glycemic control, start thromboprophylaxis, empirical antibiotic, renal support therapies, and rehabilitation because this patient required long-term ventilation. Prone position ventilation has some benefit, but not all patients improve after resupination. With changes of position, the medical devices, the drain, the tube may dislodge, and performing procedure and CPR is very challenging. So there are multiple comorbidities, there are multiple complications. Here I will highlight some of them. If eyes are not properly covered or taped or protected, there may be a chances of optic disc edema and postoperative visual loss. There may be a chances of skin and facial necrosis. There is reduced lymphatic and venous drainage that leads to swelling of tongue and lip. If the neck is overextended, there will be a chances of cervical cord injury. If the arms are not positioned well or over abducted, there may be a chances of brachial plexus or ulnar or radial nerve injury. If chest is compressed, there will be a reduced chest wall compliance and high peak pressure leading to barotrauma and pneumothorax, and there may be a chances of skin and breast necrosis. If abdomen is compress, there may be chances of increased intra-abdominal pressure and visceral ischemia, and if extremities and legs are not taken care of, there may be chances of pressure ulcers. So, but this can be prevented. In that case, the nursing consideration during prone position is very important. They have to pay each and every details of the patient, like presence of pacemaker, any implant, deformity, or orthopedic surgery. They have to check the basic neurological condition. We have to check all the bedside tubing and fix this. We have to check all the medical devices, equipment, pillows, accessories like jelly pad, face cradle, if available is not, and of course, skilled, at least 5 to 6% are trained and skilled staff is required for the position. And also we have to determine the weight of the patient to determine the ability to turn the patient in bed. Patient family should aware the potential risk and complication related to this, like loss of vision. For that, eye should be closed before lubricating, and it should be taped horizontally closed. Maintain a head position above the heart level to reduce optic disc edema, and head should be rotated to 45 degrees laterally to accommodate ET tube. It is always recommended a fundus examination before and after procedure. There may be a spontaneous drainage of secretion through the nasal and oral cavity. So frequently suctioning is required, and perform mouth care very frequently. To prevent aspiration, stop rice tube feeding 1 hour prior to prone positioning. Make sure that all the bony prominence is well protected and padded, and use of alpha or air mattress is recommended, which is recommended for the prevention of pressure ulcers. Or you can use 3M Cavilon spray over the patient face or any bony prominence. It acts as a moisture barrier. Check and auscultate for breath sound every time when you are doing, and document each and every specific position, action taken in each shift. Arms should be rotated from side to side to a swimming position every second hourly, and frequently check the eyes, nose, and ear. So come to the case. This is the Ecmo setting for his. Speed was 6,200 spin, flow was 3.5 liter per minute, sleep test was 4.5 liter per minute, and FiO2 was 100, which gradually titrated and weaned off. Initially, he was sedated with injection midazolam and cis-atracurium. He was requiring some sort of NORAD to maintain a mean pressure of 65. Later, he was sedated with injection fentanyl and morphine. Injection heparin started in view of Ecmo with 200 international units per hour, and according to ACT, it has been titrated. In his course of hospitalization, he underwent many investigations, a series of chest X-ray and CT. He developed bilateral lower limb weakness. For that, neuro opinion taken. NCV was done, and it shows the mortal axonal peripheral neuropathy affecting the lower limb. He developed gangrenous limb. For that, Doppler study was done, and it was within normal limit. Diffuse subcutaneous edema and bilateral lower limb was present. So you can see the trend of the blood parameters of this patient. On day 1, his hemoglobin was 13.4, which gradually decreased to 8.5 and 6.8 on day 25. His total count was quite high, 34,000, which gradually decreased. His platelet count was 3,05,000, which was quite okay, and gradually decreased to 43,000 to 44,000 on day 13 and then 15. His INR was 1.14 on day 1, on day 5, 2.1, on day 10, 2.69, and the end it was 1.4. His urea creatine was quite okay at the beginning, but after the 1 month, he developed AKI. His albumin was quite low throughout his hospitalization, even after giving albumin infusion. His LFT was rearranged. His LDH was high, which is 544. IL-6 was 141. Ferritin was 250, 258. So we have a patient who is immunocompromised, on ventilator and Ecmo. And these patients are very difficult to manage because they have major invasive line. They got multiple doses of steroids, and it is very difficult to manage because it is very difficult to differentiate the sepsis. There are high risk of developing VAP. There are high risk of developing of bloodstream infection, and it is very difficult to recognize ventilator-associated pneumonia because there will be no chances in the X-ray. So we can assume that this patient has a septic shock because his heart rate was 154. He was requiring vasopressor of 10 ml. His temperature was 99. And so sepsis is the biggest medical emergency, and it potentially a life-threatening condition. But here, nurses plays a very significant role in identifying patient with sepsis because it is the part of routine patient examination and patient care round. The three keys for sepsis management are early identification, early antibiotic, early resuscitation. Here, the nurse's role is to anticipate and assess for signs and symptoms if the patient has positive blood culture, receiving restricted antibiotic, has examination or a chest X-ray or suspected or infected wound. They should know the acute sign of organ dysfunction, the presence of hypotension, the tachycardia, the tachypnea, and the decreased urine output, which is less than 0.5 ml per kg of body weight if there is a rain clotting disorder or LFT abnormality. Remember the red flag symptoms, and the SOFA score is a very useful trick in sepsis screening. Infection control practices pertaining to sepsis should be done timely and appropriately. Make sure that all the invasive procedure must be carried out with strict aseptic technique. We are all aware of the bundles, the hand hygiene, which is evidence-based, which is bundle, which is used to prevent the VAP, CRBSI, CUTI, and SSI. Nurses cannot do it alone, so nurses should collaborate with the other healthcare team member and infection control nurse to identify the site and source of sepsis and an organism is involved. Nurses should monitor and understand the trend of fever, and it should be timely intervened. The nurses should administer prescribed IV fluid and antibiotic and vasoactive medication timely because remember that the 1 hour is the golden hour bundle. And nurses should monitor the blood parameters, the electrolyte imbalance, the antibiotic toxicity, and nurse should also assess the patient hemodynamic status, the fluid resuscitation, the nutritional need, the oxygenation, and ventilator management. And here also patient and family education is very important. So come to the next slide. The weaning failure is another complication we have found in many patients. The use of sedation and neuromuscular blocker should not continue beyond 28 hours. After stabilization, the sedation should be stopped and gradually decrease the ventilator setting. Give a spontaneous breathing and awakening trial and see how these patients are responding. If there is any clinical deterioration, which has mentioned here, or if there is apnea or if there is hypoxia, this will give you a clear picture that this patient is not tolerating weaning. So in that case, we have to understand and treat the underlying disease and the cause. But spontaneous breathing trials should not be limited to this. It should be practiced every day. That is why sedation vacation is advocated. Another complication we have found in many ICU patients that in the long-term critical ill patient acquired neuropathy and myopathy level, which is collectively known as ICU acquired weakness. It causes generalized muscles weakness, which is more affected on the limbs and respiratory muscles, distortion of patient or distortion of protein to DNA ratio, muscle protein synthesis, and catabolic proteolysis. It is mainly caused by prolonged immobilization, oversedation, and use of neuromuscular blocker. Mechanical ventilation more than 7 days poor glycemic control, use of steroid, and septic shock. So there is no pharmacological treatment for this. Instead, prevention and early recognition of this disorder is the most important factor in management of improved subsequent outcome. Early mobilization when it is safe to do so, strict glucose monitoring, optimal use of sedation and avoiding neuromuscular blocker, avoiding use of steroid. This patient require their calorie requirements are very high. The use of nutritional therapy and fresh element is very important. Physiotherapists will help you in doing different passive ranges of motion and respiratory muscle training if patient is awake and patient. And we have seen in many cases the electric nerve stimulation is very helpful. When we talk about sedation, we have to understand the sedation scale. Richmond Agitation and Sedation Scale, which is commonly known as RAS score. It has 10 scale, which ranging from +4 to -5. The recommended goal of RAS score is 0 to -2. And a positive score gives you a diagnosis of ICU delirium that has to be taken care of. Foot drop is another complication we have seen in most of our patients. An early initiation of ankle foot prosthesis is very important. The pain management and the psychological need is to be taken very aggressively, and the peripheral nerve stimulation we have seen in many cases it has benefit because this patient may take longer time to recover. So rehabilitation is very important, and if not treated, go for surgery. So get back to the scenario. We have a patient on ventilator on Ecmo. So for this patient, percutaneous tracheostomy was done for prolonged ventilation and breathing failure. Multiple times bronchoscopy done, which shows pseudomonas, growth of pseudomonas and organeza. He developed candida in the blood and the urine, and he had multiple MDR infections. His CMA PCR count was high. He received multiple blood transfusion. He developed DIC. He developed DIC-induced gangrene of the distal limb. He was treated with multiple antibiotics, steroid, antifungal, and antiviral. See, this is how the limb ischemia and gangrene look like. Even at a therapeutic dose of vasopressor can potentially lead to the onset of symmetrical peripheral gangrene. This is the characteristic of SPG trial, which is shock, DIC, which is disseminated intravascular coagulation, and depletion of natural anticoagulant. After the acute onset of SPG, it is very important to have early conversation with the patient and the family regarding potential outcome. The only definitive treatment for gangrene is amputation of the necrotic digit after development of a clear line of demarcation. And while awaiting demarcation, auto-amputation may happen. In the meantime, local wound taken care of with antiseptic dressing, debridement, and antibiotics. We always have to perform a modified Allen test to know the circulation of the hand. What you have to do, you have to locate the ulnar and radial arteries. You have to ask the patient to make a fist about 30 seconds. Press down the ulnar and radial artery at the same time with 2 fingers. Tell patient to unclench. The palm should be clenched. Release the pressure on the ulnar artery. If the hand flushes within 5 to 15 seconds, it means that hand has good blood supply. If it does not, the circulation of the ulnar artery is not sufficient. In that case, radial artery should not be punctured. So always perform an arterial evaluation prior to cannulation, measure and document all the peripheral pulse prior to cannulation. In case of absence pulsation, arterial Doppler examination is recommended. Extreme gentleness is to be practiced in all the arterial sampling and cannulation, and multiple punctures and all failed attempts should be documented with the site and ensure that the tip of the toes are exposed to assess perfusion regularly. Start prophylaxis, record the pulse of the ipsilateral limb twice a day or by handheld probe, Doppler probe, and it should be documented. And if there is any changes in skin, or is there any sign of duskiness, cyanosis, gangrene, it should be brought to notice to the consultant as soon as possible. Remove the artery line immediately without any consent. Change it to the another location if monitoring is still indicated. Start prophylaxis and Doppler study of the affected limb. Here is another complication is the DIC, which is disseminated intravascular coagulation. Here the nurse's responsibility is the thorough examination of the entire body, observe coagulation status and CBC, and document observe perpetual ecchymosis, the hematoma, oozing and bleeding manifestation. Take care of mouth and nose and tracheostomy site because this is the common site for oozing. Assess all the IV site, assess all the extremity for capillary refill, form and pulsation, intake output, observe stool for OBT, GI content, check CBC and the coagulation and should be documented, and blood transfusion as per hospital standard and treating the underlying cause. After this much of complication, we managed to decannulate him from Ecmo on day 21. He shifted to normal ICU after COVID-19 report came negative with ventilator, later weaned off and tracheostomy was closed on day 30. All supportive care and rehabilitation continued in ward and patient got discharged on day 46 after hospitalization. This is the TLC moment, a proud moment for every nurse. So the conclusion is COVID-19 has swept all over the world, posing a great pressure on critical care resources due to large number and increasing patients needing critical care. Dynamic monitoring, early detection, and sub-treatment is the key point. Implementation of standard precautions, standard ward management, self-awareness, and safety measure for all healthcare workers, and it is always a multidisciplinary teamwork. So this is the end of my presentation. Thank you. Over to you, sir.
Thank you so much, Ms. Bhattacharya, for an exceptionally good presentation. That was very, very practical. It was very good and heartening to see the success with your patient, and pretty much all the points that Dr. Ajay mentioned looks like you had implemented and made sure that it actually worked. Since we are almost towards the end of the presentation, I'm going to jump right away to a question placed by Dr. Ravi Mahajan. And his question was, what are the 3 most important interventions in your experience which seem to make real difference in outcome in ICU COVID patients from a nursing standpoint? What do you think really made a difference?
Very nice question, sir. Early recognition of severity of disease and complication, that is the main point that I have already highlighted. And second, patient and family education in each and every stage of treatment is second most important. And we have faced so many times that this is the scenario in this is the scenario of this COVID question.
Great. All right, excellent. Thank you. That's wonderful. And Ajay, do you have any things to add about what you think were the top 3 things which made a difference?
Sure, Dr. Sai. I'm sure you will also want to add upon that. With regards to intubated patients, I think prone ventilation, early proning really helped. Good supportive care. I think that's what meant. I mean, whatever we are doing in critical care before, nothing different for COVID. Good organ supportive care. And third, in the patients who are just about to get, just come into the ICU, I think early steroids and just picking the right points to give the immunomodulators, tocilizumab, anticoagulation. I think these are the things. These were, I think, proning, supportive care do less harm overall. So that's what I think.
Great. I think
matters.
Yeah, excellent. I think these are all just very simple points and excellent points. And again, thank you both for such a wonderful session. And again, we have people from all over India who are watching this. Now, you may not realize it, but I don't think this happens anywhere else in the world. We have an entire spectrum of nurses and doctors on the same platform for about 90 minutes talking about such a wonderful topic in such an excellent, like really evidence-based, practical way. And you're really going to, I'm really appreciating the entire effort put by both of you and the team for the back end by Jude and Dr. Ravi to really make this happen. Now, you may know that our nurses are, of course, at the center of all this. Last time when I gave my talk on asthma, we talked about our nurses perhaps auscultating patients and giving us input on wheezing, crackles, things like that. And you may be happy to know that there's a conversation that's been started by our nursing team, Captain Banerjee, as well as the rest of the team who have been looking into that. The other interesting thing is that we do have a newsletter coming out. If you go to the website, which is listed on your chat, you do have the link which has the entire newsletter from last time. There's also a crossword, and I don't know how hard it was. I made that one. I don't know how many actually even tried it. This time there's going to be multiple articles from around the country, and for the first time we're going to have our nurses contributing, and there will be 2 to 3 articles by them which are very interesting. I've looked at those. We're working on making it come through. And each of these sessions is going to be every month. The next one, I believe, is on critical care transportation and moving patients and moving a patient from one place to the other, doing it safely by Dr. Pratima and our nursing team. I believe the nurse would be Jude. Can you tell me who is doing the talk next month? I believe that's already planned, and that is on.
Doctor, it will be by Ms. Mitiben Patel from Apollo Hospitals, Ahmedabad.
Oh, great. And Dr. Pratima from Chennai. And that's on 24th of November, so not too far away. So look forward to that. So you have multiple things coming up, and the center has taken off very well. And there is plenty of good information available on the site. I would encourage all of you to contribute to the newsletter, contribute to the website. If you have any articles, please start doing research. And Ajay mentioned about the protocols that we all have. Now there are Apollo-wide protocol. So luckily it started off in one place, and there's a whole group of doctors and nurses who have been participating in making the care uniform. And one of the missions of the entire, this whole effort is to make sure that we all give the similar pattern of evidence-based care. The name of the drug might be different, but ultimately, it's the same kind of care that's being given. And the fast hug bids, which we talked about, probably saves more lives than anything else that we do, and preventing the injuries that can be prevented, including things like pressure ulcers, pressure sores. These are all extremely important. So I'm going to kind of wait for another 30 seconds or so if anybody has any burning questions they want to ask before they head off home and indulge in the sweets for Diwali. So let me know if you have any other questions. But overall, what we learned today was that COVID is a crisis, but COVID has been managed effectively by integrated care. We've realized that the basic knowledge patterns are the same. Kindly do your best to keep up to date, because the COVID epidemic has shown us how things are changing on almost a daily to weekly basis. But what we have realized is with coordinated partnership, we can keep our patients healthy and really well. Captain Banerjee, are you online? Would you want to add something? And Dr. Ravi, if you're online, would you like to add something before we close?
Dr. Sai, I'm Muthuram here.
Muthuram, please go ahead.
Banerjee has gone for an important meeting. She asked me to represent in fact.
Please go ahead, Ms. Muthuram. Briefly, if you want to share any thoughts.
Yeah, I would like to share the great challenge in the patients dealt in the COVID area was like nurses, number of nurses requirement. So it had given an insight for us to train the nurses in a cross-functional way. ICU and wards. Now, I think this COVID brought a very nice insight and outcome that the nurses should be cross-trained. At any time, they should be able to handle the ventilator. And the second thing is like importance of closed suction and the positioning of the patients. Prevention of pressure injury. Again, great challenge was again nutrition of the patients. We may provide whatever the food calories we calculate and give because of the loss of taste and smell. They were not able to eat, and whatever liquids we give, they say it is not hot, it is cold. The great challenges we faced, and the area being isolated, not much people of others can help. Only the nurses and doctors were the trained worker over there, and they have to meet all the requirement of the patients. So I think the nurse and the doctor play a vital role in taking care of the patients in the COVID area. And it also gives like handling humidifier, ventilator, the cleanliness of the humidifier, how to clean, autoclave, sterilization. This all, everyone, including the person emptying the, cleaning the humidifier, like our attendant boy, need to be educated. So on the whole, I would like to sum up the saying that continuous education, cross-functional training would help the nurses to work in ICU and ward would be the great help for us.
Great. Thank you, Ms. Muthuram. Excellent points. I'm going to request Dr. Ravi to see if he has any words to add.
Nothing more to add. I think it's been an excellent session as always, and just brilliant Ajay, Kavita, nice presentations, excellent moderation, Sai. I think all the essential learning points have been so well highlighted, and I'm sure the audience here will appreciate. I don't know what Diwali or post-Diwali might look like. We may have or we may not have a third surge, but whatever, I think COVID is still around. We still have patients who come to ICU, and as we've learned today, it's the basic good ICU management that saves the life. So brilliant session. Thank you very much indeed. Thank you.
Thank you, Dr. Ravi. So I'm going to close with a quotation that I really like. It is, sorry, Pinaki, go ahead, please, go ahead.
Yeah. Good evening to everyone and happy Diwali to each one of you. And we are ending with a very good session and starting Diwali tomorrow. And thank you once again, both the speaker, Dr. Ajay, Kavita has done a wonderful job, no doubt about it. I rather comment about that. I think you said about standardization. So oxygen goal for ICU, the way it was displayed by Dr. Ajay from main hospital, probably you can standardize across Apollo. Like I work in Guwahati, I do not see that standardization. So I think we can speak in a bigger forum like in our steering committee, and you can come up with this kind of standardization and the protocol, because we don't know, maybe we will face third wave. So we may have to go with a little more different way of dealing COVID. And Kavita has really expressed very well about prone position. Yes, we had a lot of challenges and not to mention many things, but yes, we did lost one case because of like proning, and nurses were not that competent enough to understand about what is the requirement. So there was a tube, accidental extubation was there. So this kind of point, I think vigorously we need to talk, and let us have a standardized protocol to look into what specific nursing care is required, and skill-based program probably we can enroll or can go ahead with some kind of video where every nurse is dealing with COVID, especially critical care unit. I think they should be extremely careful about dealing with COVID, because any moment people deteriorate and die. We have seen a lot of death last year. And so that's what my comment. And again, thank you so much, Professor Ravi, wonderful forum. And we started having 2 sessions per month, so we can have maybe next year every week 1 session, if at all required. So thank you once again. Nurses are doing fantastic, along with a lot of leading consultants, one team in Apollo. Fantastic job, and good luck to each one of you.
Great, thank you, Ms. Pinaki. Excellent points. I think we'll close with, I'm just going to, just this favorite quote of mine is, what the mind does not know, the eye does not see. So as long as you really need the knowledge to be aware of what you're observing. So it's very important that you stay up to date, especially with the critical care, because things are rapidly evolving and things are getting better. The equipment's getting better. People are using ultrasound everywhere. So these are places where you can actually collaborate with your doctors, because there's a lot of good that'll come for patients. And of course, never stop learning, because life never stops teaching. So with that, I'm going to close. And again, thank you all, and wish you all a wonderful Diwali and a great festive season. Take care. Bye-bye.